Hi student, I am Dr. C. Suresh, Associate Professor, Department of Oral and Maxillofacial Surgery, Vinayak Mission Sankaracharya Dental College, Salem. I am going to brief about trigeminal neuralgia. So facial neuropathology briefly divided into the trigeminal neuralgia, nerve injuries, facial palsy. So today I am going to brief about trigeminal neuralgia. So trigeminal neuralgia, otherwise called as a Dick Dollerex. So dicto is it's a painful jerking movements. So it's first described by John Fothergill in 1773. It's a published in detailed description of the trigeminal neuralgia in Fothergill's disease. So we want to define the trigeminal neuralgia as a sudden, usually unilateral, severe, brief, stabbing, lancinating, paroxysmal, recurring pain in the distribution of one or more branches of fifth cranial nerve. It's otherwise called as the trigeminal nerve. So we want to know about is a usually sudden, okay, is usually coming as a episode of sudden, is affecting the only one side of the face maximum. So unilateral, severe pain and a brief and stabbing, lancinating type of pain. Is a unique of paroxysmal pain is recurring in the distribution of the any one of the branch of the trigeminal nerve. So trigeminal neuralgia is a orofacial pain restricted one or more division of the trigeminal nerve. So it's only restricted in the trigeminal nerve branches. We know the trigeminal nerve branches: ophthalmic, maxillary, mandible. This branch is only involving. So general history of the trigeminal neuralgia, incidence about rare applications about 4 in the 1 lakh population. Age is commonly is late middle age or later in the life. It's about 5th or 6th decades. Sex predilection somewhat more on the female pupils, about 58%. It's 1.6 more than the 1. So ablation of the side, so maximum effect in the right side is about 60%. So maximum involvement of the branch is V3 branch. V3 branch is a mandibular branch. V1 is ophthalmic, V2 is a maxillary, V3 is a mandible. So V3 is a mandibular branch is most commonly involved than the maxillary branch. Very rarely ophthalmic branch is affected, about 5% of the cases. Only sensory division. So about 1 to 3% of the patient affect the all 3 branches. So only rarely all 3 branches involved, about only 1 to 3 branch of the things. And also patient of the multiple sclerosis, it may be having the bilateral involvement. So we know definition itself defines the unilateral involvement. But sometimes is only 1 to 3% patient who have the multiple sclerosis, they may be having the bilateral involvement. So some rare situation. So we are going for the etiology of the trigeminal neuralgia. So multiple sclerosis. So multiple sclerosis lesions in the involved in the nerve root ganglion region. And also Peter's ridge basal compression is often due to the intracranial tumors, any benign tumors, and also intracranial vascular abnormalities. Is maybe internal carotidity, aneurysms, or AV malformation, anything. And also dental etiology. Due to the extraction of the teeth, nerve endings may have the neuromas. Infection may be granulomatous infection or non-granulomatous infection. Viral etiology, post-herpetic neuralgia, we know that may be the reason. Then post-traumatic neuralgia. So any trauma, after trauma is now getting neuroma. And retinous jawbone cavities. Retinous jawbone cavities means it may be affected in the patient alveolar bone or the jaw bones. So it getting the cavities. So pathogenesis is not clear. So most common reason may be accepted is compression of the trigeminal nerve root within a few millimeter of the entry into the pons. This is the main reason for the trigeminal neuralgia. So nerve impingement is often accompanied by the demyelination of the sensory fibers within the nerve root or root entry zone, or less commonly in the brainstem. The short circuiting of the demyelination axon resulting in the paroxysm of the pain. So we want to know is a compression happen in the nerve root ganglion. The nerve where is the nerve root is arises, that areas getting compression, impingement. That's why getting what happened, myelination fibers getting demyelinated. So that's why patient getting the paroxysms like a pain. So this is different from the other pains. So according to the Ignition's hypothesis, abnormal firing is a resultant to an injury to the myelin layer of the trigeminal nerve due to the compression of the its point of entry in the posterior fossa. This hypothesis explains abnormal pain. That's why patient getting severe lancinating paroxysmal pain. So is a very important point you want to mention anywhere. Pathogenesis means is abnormal firing in the result to the injury to the myelinating layer of the trigeminal nerve due to the compression at the point of the posterior fossa. So patient getting severe pain. So clinical picture. So we going for the clinical picture. So trigeminal neuralgia already definition itself explains sudden, unilateral. So sudden patient getting sudden attack and unilateral. So one side of the space usually attack and intermittent. So it getting some time. Whereas paroxysmal is a paroxysmal kind of pain, squeezing kind type, sharp and shooting, lancinating, shock-like pain. So patient getting shock-like pain elicited by the slight touch superficial of the trigger points. This is a very important point. So this trigeminal neuralgia getting that trigger points. So some areas having a trigger points. That points we getting the touch as even as a slight touch getting patient getting the stimulating the this kind of pain, which radiates across the distribution of the these trigeminal nerve branches. So pain is rarely bilateral. I told already previous slide 1 to 4% only bilateral. So pain is usually confined to one part of the one division of the trigeminal nerve. So any one branch, maximum we already see there is a mandibular branch is maximum affected than the maxillary branch. So any one branch only maximum affected. So mandibular or maxillary, but occasionally only some adjacent division are rarely involved the all three divisions. Pain rarely cross the midline. So I told you already, so one side of the face only involved, but rarely cross the opposite side, midline. So pain is short duration, last few seconds to the 2 minutes. So short duration of the short pain is few seconds to 2 minutes, but may occur with the variable frequency. Even though there is a refractory period, complete lack of the pain, but between the attacks, some patients report to dull ache in the between attacks. So did trigeminal neuralgia have the refractory period? So some short time no pain, but some patient having a dull pain. Even the refractory period time also, that time also patient getting dull pain. During an attack, patient grimaces with the pain, clutches hand over the affected side of the face, stopping all the activities and is rubbing the space involved with the part which may be reddened or eye and also water until the attack subsided. So what happened means patient, for example, patient having a maxillary branch means that can't bear the pain. That's why you holding the hands in the that facial region and clenches and also sometimes rubbing. That's why that region getting redness and also eye getting the water. So any branch affecting patient getting holding that region. So male patient, for example, male patient avoiding the shaving because that touching trigger points. With touching means pain getting more involved. That's why patient avoiding the shaving, male patient. And also patient intraorally we examining means oral hygiene is very poor, avoiding the brushing the tooth also because that are the trigger points there, gums, teeth also. So with each attack the pain seems to become more intense and unbearable. So day by day every attack it's the intensity of the pain is more. That is the important point. That's why day by day patient getting more pain. So unbearable also. In extreme cases patient will have motionless faces. So this is the important point that asking one more question, a Proson or mask like pace. So which condition patient getting Proson or mask like pace means it's a trigeminal neuralgia. So we are going coming to the clinical picture, we going coming for the trigger zone. It's the area of the facial skin or oral mucosa. In maximum facial skin or oral mucosa having a low intensity mechanical stimulation or light touch or hair puff, or even touching the face or particular site, or by shaving or smiling or speaking or brushing or shaving or even washing the face can elicit the typical pain attack. These are the condition patient getting the elicit the typical attack. So we want to know the three branches, where are the trigger points. V1 branch or ophthalmic branch, our zone is a supraorbital ridge of the affected side. So supraorbital ridge is a trigger point for the ophthalmic branch, V1 branch. V2 branch, maxillary branch. Here skin of the upper lip, ala, nase, cheek, upper gum. These are the areas patient having a trigger point for maxillary branch. So we want to know, it's very important point, upper lip, ala of the nase or cheek or on the gum of the upper teeth gum. So V3 branch or mandibular branch. So lower lip, teeth or gum of the lower jaw and the tongue is very rare. So these are the points we want to remember. This particular area we make a slight touch or hair or even normal activity we doing, patient getting pain that particular region. So it's a characteristic of the disorder that attacks do not occur during the sleep. This is a very important point in trigeminal neuralgia. So odontogenic pain maximum patient having the while sleep. So can't sleep the patient, but in trigeminal neuralgia classically it's not attack during the sleep. So it is a differentiation from the odontogenic pain. So you want to ask the history, proper history, is while sleeping the time is attack coming or not. That is maybe give you the clue for trigeminal neuralgia. It is a very common for this patient to undergo indiscriminate dental extraction on the affected side without any relief of the pain. So because of pain trigger zone pain fiber distribution of the mimic the pain of odontogenic origin. So nothing but because of the patient trigger zone in the upper gums or lower gum and cheek region, teeth region, patient have a trigger zone. So patient thinks this is a odontogenic pain. Pain is due to the dental origin or pulpal origin. That's why misunderstanding and misdiagnosis going for the dental extraction. So we want to diagnose the trigeminal neuralgia by worldwide accepted criteria is called as a white and sweet criteria. Though according to this criteria is a 5 criteria is there. So pain is a paroxysmal. Pain is a paroxysmal. And pain may be provoked by the light touch to the face and the trigger zones. I already explained. Pain is confined to the trigeminal distribution. It's only trigeminal nerve branches. Pain is unilateral, only unilateral. So clinical sensory examination is normal. Other sensory clinical examination is normal. This 5 criteria. So pain is a very quiescing kind of pain, and pain may be provoked by the light touch. It's a trigger zone while touching. For example, maxillary branch means is the upper cheek region, alanaceae or upper gum region. Mandible means we know lower lip region, gum region, teeth region. So this region with touching means while small giving you some trigger, it gives the pain. Pain may be confined only trigeminal distribution, that branches only. Pain is the unilateral. Clinical sensory examination, other clinical sensory examination may be normal. This is the 5 criteria. It's important for diagnosis of the trigeminal neuralgia. So this flow chart is helping for the patient, any patient coming with neural pain, we can classify the trigeminal neuralgia or other pain. For example, evaluation of the using formal diagnostic criteria. So previously I worldwide accepting white and sweet criteria I told. So does patient match the trigeminal criteria? This criteria patient match means go for the imaging studies, any MRI or CT. Any intracranial lesions there or not want to there. So imaging there is a yes, imaging any finding there, so going for that is a classical trigeminal neuralgia. So we go for the medical management. Medical management trial of anti-epileptic drugs we giving. Pain relieves going for the maintain the drugs. In case patient does not match this white and sweet criteria, go for the consider other disease. So 5 criteria want to match, and also matches, but imaging study MRI or any CT scan gives no typical lesions inside the cranium. So go for the symptomatic trigeminal neuralgia, and a neurosurgeon consult want to do and consider for any other surgical treatment. So even after medical management, patient is having a no pain relief. So go for the addition of the another one drug, anti-epileptic drug. So if patient getting relief from this another drug adding, go for the medical management only. But after adding the other medication also, patient getting no relieving of the pain after giving the adding the second drug or multiple drugs also. Again we want to check the patient is fitting with this 5 criteria. So does patient truly fit for trigeminal neuralgia criteria? So if again going by white and sweet criteria is fitting, really patient getting trigeminal neuralgia, so go for the yes. So is a medical management is not working, so go for the surgical treatment. This is a flow chart explaining the how the patient to evaluate diagnose the patient coming with the pain. So again going for the diagnostic local anesthetic of peripheral nerve blocks. This is diagnostic nerve blocks. So what we do is we want to have the 3 cc syringes with a saline, 2% lidocaine without atolline we want to have. So first we want to know where the pain surface. We want to start from the surface. Patient having a surface pain, we want first to inject 0.5 ml of the saline injection. Though then patient relieving the pain, it's a psychological pain. In case patient still having a pain, we want to give the 0.5 ml of the 2% lidocaine without atolline, that particular surface. So patient relieving means the particular terminal branches involving. So still patient getting pain, we want to give the injection 0.5 ml of 2% lidocaine deep muscularly. So patient relieving the pain is a muscular pain. So want to categorize as muscular pain. Still patient getting pain, we want to give the For example, mandibular branch is mental nerve block. So mental nerve block relieving means pain relieving means it's a mental branch involving that mental branch involving. We want to go for the treatment accordingly. Otherwise, we go for the again inferior alveolar nerve block. That means that inferior alveolar branch involving. So from distal to proximally, we go for the one next branches. Okay, like that we want to give the anesthesia, local anesthesia and saline, and differentiate the patient really having trigeminal neuralgia or psychological pain. So while once we diagnose a patient as a trigeminal neuralgia, go for the management. So what kind of management is there? So trigeminal neuralgia, two managements there, medical and surgical. So medical is separately there, lot of medications, and surgical is also vast number of the surgical modalities there. We can see one by one. So medical management. Medical management maximum used very familiar drug is carbamazepine. 100 milligram BID is a loading dose up to 1200 to 2400 milligram is a want to give. Other drugs we are going for the gabapentin, beclopin, clonazepam, lamotrigine, oxcarbazepine, topiramate, phenytoin, valproic acid. These are the drugs we can give. But maximum giving is a carbamazepine, tegretol. Starting with a small dose, but day by day is intensity of pain is increasing. That's why we can increase the dosage up also. If one drug is not enough, is not relieve the pain, we want to add them another drug. That drug also not relieving means we want to go for the multiple drug therapy. We go for the multiple drug therapy. So while giving the drug therapy medical management, we want to know the side effect of that particular drug also. So what are the side effect of the carbamazepine? Visual blurring, dizziness, somnolence, skin rashes, ataxia, and also rare case of hepatic dysfunction. So some patient having leukopenia, thrombocytopenia, ablastic anemia, it is known as the bone marrow suppression. So in frequently some duration time we want to take the patient blood test correct or not, because it have more side effects. Surgical treatments. So a lot of neurosurgical treatment are also there, and peripheral neurotomy procedures also there. We can explain one by one. So surgical treatments we can go for with broadly classified into two types: ablative surgical procedure, non-ablative surgical procedure. Ablative surgical procedure is going for the peripheral. Peripheral, what are the things we can do? The cryotherapy, radiofrequency, neurectomy, alcohol injection, peripheral neurectomy. Gastrin ganglion surgeries is a partial sensory thermocoagulation, glycerol rhizolysis, balloon compression. These are the gastrin ganglion procedure. The posterior procedure is a rhizotomy, gamma knife, radiosurgery. So non-ablative surgery is a microvascular decompression. Though these are the surgical modalities there, we can see briefly one by one. So peripheral nerve injections. So we usually giving the long-acting anesthetic agent like a bupivacaine. So bupivacaine is a long-acting local anesthesia, and also we can go for the local alcohol injections. 95% absolute alcohol. We can go for the injection. Then we go for the peripheral neurectomy as a nerve avulsion. This is a surgical procedure. We can maxillofacial surgeons do. It acts by interrupting while doing this procedure. What happening means it acts by interrupting the flow of the significant number of apparent impulse. So the central trigeminal apparatus. So while doing the nerve avulsion, what happens means the flow is already explained, the abnormal flowing of the signals. So it can interrupt the flow of this apparent impulse. So patient getting the relieving of the pain. It's indicated in the patient. It mainly indicated for the patient is contraindicated for the surgeries because of age-related problem or a significant systemic diseases or a limited life expectancy. So this kind of situation, we may be this peripheral neurectomy may be indicated and advised. So peripheral neurectomy having the maxillary branch infraorbital neurectomy. So infraorbital neurectomy, two approaches there. One approach intraoral conventional approach. Another one is a bronze transandral approach. Is described in 1977. So we can briefly see the intraoral conventional approach. The intraoral conventional approach is nothing but we can put the incision as a U-shape intraoral vestibular incision is called a loop incision. We put in the canine fossa region. We can elevate the mucoperiosteal flap, and also we can identify the infraorbital foramen. So we can see the infraorbital nerve. So we want to hold the hemostat in the nerve, and also distal portion of the temporal branches in the skin. We want to relieve the things, and also relieve and pull the nerve from the skin, and also we want to cut maximum as possible inside the foramen the nerve, and also tied with the line and suture. Foramen want to filled with the polyethylene material. So this picture showing how to pull out in the this infraorbital nerve from the infraorbital foramen. So this is a intraoral conventional approach. For neurectomy we are doing for the maxillary infraorbital branch involving means we can do this procedure, and the suturing done as usual. The bronze transantral approach is we putting the intraoral same for maxillary branch. We putting the intraoral incisions, vestibular incision from the tuberosity to the up to midline. Mucoperiosteal flap is elevated. Then we want to make the window in the lateral of the maxilla. While we opening the window, we want to trace the descending palatine nerve. The descending palatine nerve up to the spinopalatine ganglion. From the spinopalatine ganglion, we can trace the nerve up to the foramen rotundum, maxillary branch. So main is coming out from the foramen rotundum. So from that region, we want to cut the nerve and pull out from the whole branch. So this transcentral approach is very useful for the if the maxillary branch is involving, we want to do the neurectomy procedure. Then we can suture the incision region as usual. Then we go for the inferior alveolar neurectomy. So inferior alveolar neurectomy is a mandibular nerve branch, inferior alveolar nerve. So this in inferior alveolar neurectomy we can do the extraoral approach. Is nothing but a Risdon approach or intraoral approach. So maximum intraoral approach we using, extraoral approach we using as per a Risdon approach, but intraoral approach very useful to avoid the scare everything. So it is mainly described by Dr. Jinwala. So that's why we called as a Jinwala incision. This incision is called as a Jinwala incision. It mainly used in the dentulous patient. So incision is made along the anterior border of the ascending ramus. So extending the lingually and buccally two ends like a fork. So it's like a inverted Y-shaped incision. After the two incisions, Y-shaped incision buccal and lingual, two heavy black line and thread are looped around the nerve we can see. And the imperial nerve is coming and entering the mandibular foramen. So we can hold the nerve using the nerve hook, and also we want to have a two heavy line and thread, and want to tie as maximum as possible more height. This is doing the more high possible, and also we want to cauterize that upper end, and while dividing the lower end is held in the hemostat. So want to hold the nerve in the lower end in the hemostat. Then another linear incision want to made in the buccal vestibular region in the mental foramen, because it's the terminal branch is coming out of the mental foramen. So mucoperiosteal flap is want to reflect and expose the mental nerve. Then is want to tie heavy black line with a little away from the foramen, and now is then want to cut with the hemostat, and distal knot want to do the knot and division with the 2. So distal part of the holding the nerve in the hemostat. So around the peripheral branches we entering the mucosa what avulsed out, like inferior alveolar nerve want to avulsed out the peripheral branches from the skin everything. While we avulsing, so skin surface may be getting the buckling. Now after the mental nerve is freed from the mental foramen, then mandibular foramen, the distal part of the nerve which is held in the hemostat is pulled until the entire length of the canal is avulsed out. So like this want to remove the entire inferior alveolar nerve from the canal. So while starting the before entering the mandibular foramen and from the mental foramen, so full length want to pulled out, and the wound is closed by interrupting sutures. So this is now with this picture showing how to ligating the nerve endings and with the line and sutures, and how the holding the nerve by the using the hemostat, and this picture showing the full avulsed nerve neurectomy in perialveolar nerve is a branches also, so peripheral branches avulsed from the lip regions. This is a tied line and sutures in the before entering the mandibular foramen eye area, more possible eye region. Like that, in perialveolar neurectomy, go for the lingual neurectomy. Lingual neurectomy also want to put the incision in the anterior ramus region. So while want to mucoperiosteal flap reflected, so we can see the lingual nerve along the anterior part of the middle pterygoid muscle. So we can identify, we want to tie the lingual nerve as possible more eye position with the line and sutures, want to cut and also avulse the entire nerve from the tongue. This is a lingual neurectomy. So next we go for the cryotherapy. Cryotherapy usually used by the less than minus 60 degrees Celsius temperature. So while using the cryotherapy, what happened means the nerve root endings getting the Valerian degeneration. So it relieves the pain. So cryoprobe is usually used is nitrous oxide probe. About the 1 to 2 minutes followed by the 3 minutes thawing we using this. So every 3 minutes thawing repeated after 3 minutes. This is the cryotherapy we giving. Then next procedure is a peripheral radiofrequency neurolysis or thermocoagulation. So it's described by the Gregg and Small in 1986. Is reported surgical management trigeminal pain with a radiofrequency lesion of the peripheral nerves. So radiofrequency electrode that has capacity to definitely destroy the pain fibers used this procedure. So while using this radiofrequency thermal coagulation, the pain fibers is destroyed. That's why patient getting the relieving the from the trigeminal neuralgia. So radiofrequency neurolysis has been shown induce the pain remission about 80% of the cases. So only 20% only having the recurrence rate. So 80% of the patient getting relieving from the pain. So that's why the very useful for the peripheral radiofrequency neurolysis. So this procedure having the 22 gauge lesion probe. The temperature used is at 65 to 75 degrees Celsius for 1 to 2 minutes. Low morbidity in high risk or elderly patient. So this procedure may maximum using for the elderly patient because this procedure gives low morbidity only. Then we go for the Gesserian ganglion procedure. So this is the previously we see in the peripheral procedures. Now we go for the Gesserian ganglion procedure. So usually we can inject the glycerol injection, thermocoagulation, balloon compression. This three procedure can do the Gesserian ganglion. So we using this procedure by using the percutaneous technique. Hertel 3-point marking is want to mark. So first we want to mark the one line, perpendicular line from the lateral orbital rim to the perpendicular to the lower bar of the mandible. So one line, first line want to draw from lateral orbital rim downward, perpendicular to the lower part of the mandible. So sign point from angle of the mandible, so 15 millimeter one point is putting. This is the entry of the needle. Another point is 2.5 centimeter from the external acoustic master to the TMJ region. That is the plane of the injection going. Though this 3 point is very important. So needle is want to enter this first point and go inside and the plane up to reaching the foramen oval. So while entering the needle inside, we want to put one finger inside the buccal mucosa because it's not coming out to inside the oral cavity. It goes inside and entering to the, while hitting the anterior ramus, it's going to slightly moving to the medial to the anterior ramus and go inside and reaching the foramen oval. So to identify to confirm the correct plane of the needle, we want to take the submental vertex view, biplanar radiology image intensifier want to intraoperatively want to take. So this imaging correctly giving the site of the needle goes inside and target region. Entry of the foramen oval also is identifying. So it's very useful for biplanar radiology while advancing the needle inside. So once needle is reaching the foramen oval, want to inject the because near to the foramen oval inside the Gesserian ganglion is present. That ganglion. So before inject the solution, we want to slightly. Usually we using the 16 gauge spinal needle only. Slightly want to stylate. Want to remove the want to confirm CS release is coming is correctly reaching the ganglion. So we want to use the glycerol or absolute alcohol. Glycerol or absolute alcohol is using for the injection purpose. This gives the low grade damage to the by the dehydration of the nerve root region. So it's making very low grade damage by dehydration by using the glycerol or absolute alcohol. Usually 0.5 to 0.7 ml of the pure glycerol or 0.5 ml of the absolute alcohol is using for this injection purpose. This picture showing how the spinal needle enter inside and reaching the Gesserian ganglion and injection and how the pain is relieving. So same like controlled radiofrequency thermocoagulation we doing like the percutaneous technique. So about 30 to 90 second duration we doing 65 to 75 degrees Celsius using radio frequency generator of microwave energy is using for this thermal coagulation. So power is 25 watts, voltage is 40 to 45 volts, current is 120 to 140 milliampere. So lesion is about 10 millimeter to into 6 millimeter within the trigeminal root at 75 degrees Celsius. So that level of the lesion is making while using the thermocoagulation. So same like a percutaneous technique, we enter the probe inside and reach the glycerin ganglion, we making the this lesion about 10 millimeter into 6 millimeter. So patient getting pain relief. This is the thermocoagulation equipment, how that is doing. So third procedure is balloon compression. So Fogarty catheter is used for this purpose. So while inflating the balloon at the ventral aspect of the ganglion root, so used. So while compression, the patient getting the pain relief. So usually for this purpose, 12 gauge fine needle used as earlier told. So inflated for the 1 minute. So while balloon compression is happened, like percussion is this also percussion technique goes inside. While inflating for 1 minute, the ventral aspect of the ganglion root getting compressed, so patient getting pain relieved. So now going for the neurosurgical procedure, otherwise open procedure, intracranial procedure. Usually microvascular decompression is doing for the superior cerebral artery aneurysms or any abnormalities or malformations. Usually we keeping the because the superior cerebral artery is mainly compression on the nerve root ganglion. So we want to decompress this superior cerebral artery by using the sponge or Teflon wool. So next trigeminal root suction. Extradural sensory root suction procedure is mainly explained by the Frazier approach in 1901. Retrogesserian rhizotomy is a neurosurgery procedure. Retrogesserian rhizotomy we can do. Is an extradural sensory root suction, but intradural root suction is explained by the Wilkins 1966. Less chance of damage to the superior petrosal nerve and the facial nerve, less chance of bleeding. This technique is advantage over the extradural sensory root suction. So trigeminal tractotomy is a medullary tractotomy. The incision of the descending trigeminal tract near the cervicomedullary junction we can do. So this is another procedure. So we could go for the now recently updated procedures. Percutaneous stereotactic radiofrequency thermal lesion of the trigeminal ganglion under the root of the trigeminal ganglion. So this makes the thermal lesions with a less morbidity. So then another technique is a posterior fossa exploration and microvascular decompression of the trigeminal root. Another technique is a gamma knife, is advanced technique, gamma knife radiation to the trigeminal root entry zone. So these three procedures is updating procedure. So glycerin ganglion procedure is a percutaneous radiofrequency thermocoagulation trigeminal gangliolysis or radiofrequency trichotomy. So what happens means electric current is passed through the needle probing thermal lesion in the glycerin ganglion is a disturb in the pain signals. Already I explained percutaneously we can enter into the glycerin ganglion via foramen ovale. So electric current is passed. So what happens? Thermal lesion is I told is made in the nerve root ganglion region. So pain signal is getting disturbed, patient getting relieved. Then percutaneous retrogesserian glycerol rhizolysis or rhizotomy, chemical rhizotomy. By injecting 0.1 to 0.4 ml of the glycerol into the trigeminal cistern or glycerol injected into the destroy the pain transmitting nerve in the glycerin ganglion. So glycerol is 0.1 to 0.4 ml is injected. Same balloon microcompression already I told rhizotomy or so up to glycerin ganglion is 10 minutes to damage it or block the pain signals. So this balloon may be compressed and damage the while giving the this damage the block the pain signals. So central neurosurgical procedure is gamma knife radiation. So it's an advanced treatment. It's a Lars Laxell. It's a 1951. I explained this technique. Invented a gamma knife. The gamma knife is a complex machine which uses a Gopal 60 as the energy source for the radiosurgery. This gamma knife delivers a precious controlled beam of the radiation to the trigeminal nerve, where it connects to the brainstem and thereby directly stop the pain signal transmission. So while using like this, the pain signals directly stopped by intermediate the gamma knife deliver this kind of signals. So high dose of 70 to 90 gray of the highly focused beam of the radiation is delivered to the trigeminal root entry zone, which over time causes the axonal degeneration and necrosis and interrupts the pain signals. So this high dose of the 70 to 90 grays of the radiation we deliver the nerve root ganglion. So it causes axonal degeneration, necrosis. Is completely necrosis happen. So interrupt the pain signals, patient relieving the pain. Duration of the treatment is about 15 to 40 minutes taking the time. Pain relieved delayed up to 1 month within this procedure. So pain will be getting up to 1 month. So microvascular decompression of the sensory root trigeminal nerve is a procedure popularized by the Janata 1967 to 1976. This technique also called as a Janata technique, microvascular decompression of the sensory root of the trigeminal nerve. Most commonly performed intracranial open procedure. It's a open procedure. Microvascular decompression mostly invasive surgery, but was the highest success rate of the pain. Pre-status of the pain within the classic trigeminal neuralgia. So this is a procedure giving the highest rate of the success. Is done under GA only. Involves retrosigmoid craniotomy. So the approach is a retrosigmoid craniotomy and micro surgical exploration of the posterior fossa did and incision made over the mastoid area. By this area we go inside and decompress the lesion. So open craniotomy approach gain the access to the trigeminal root entry into the adjacent brainstem. The compression branch of the superior cerebral artery already told earlier. So superior cerebral artery is a compression with a medial to the nerve to root entry. So compressing or pulsating arteries carefully separate from the trigeminal nerve and interpositioned by using the non-absorbable insulating sponge or Teflon wool. So we want to very careful while separating the superior cerebral artery from the nerve compression in the nerve root ganglion, and also by using the non-absorbable insulating sponge or Teflon wool want to keep between them or to avoid the recurrence. The patient usually retain the good facial sensation without aesthetic dysfunction. So while doing this procedure, not any facial nerve involvement is happen. There is a patient getting no facial sensation, and also facial sensory function also not affecting. So immediate pain relief success about 90 to 5%. So by doing this Janata procedure, so 95% success rate is happen. We want to separate the superior cerebral artery and compression on the root region. And also we want to keep intermediate material like a sponge or Teflon wool to avoid the recurrence. So these are the procedures, medical management and surgical management we see. Surgical management we see in the peripheral procedure and also central procedures. So now finally we go coming with the complications. So while doing the peripheral procedure, patient may be getting the hypoesthesia, dysesthesia, paresthesia and high requirement of the analgesics, persisting paroxysm several days after neurectomy. It may be happen because we are doing the peripheral neurectomy every procedure, patient getting the paresthesia, maximum getting more pain, though getting the more volume of the amount of the dosage of the analgesics want to give. And the percutaneous technique, diminished corneal reflex may be happen. That's why while doing we want to take the radiograph also. And also anesthesia dolor also happen. Masseter weakness and paralysis may be happen because we going in the medial to the ramus, and a permanent palsy of the abdominal nerve may be possible. CSF leakage with checking usually that may be permanent. Aseptic meningitis, carotid cavernous fistula may be possible. These are the complications happen the percutaneous technique. While doing the central procedure, maybe chance of 0.2% of the death may be possible. Brainstem infarction may be 0.1% is possible. Ipsilateral hearing loss may be possible about 1% of the patient. Hypoesthesia and disappearance of the corneal reflection, mastocytosis, atopia, paresthesia, trachypnea and hearing loss, vertigo, tinnitus may be the possible complications happen. So more about ear problems, CSF leakage may be possible, and the ear loss, persistent diplopia. So ear complications, eye complications more possible. Facial numbness, so 36% of the facial numbness is possible. So persistent paresthesia, persistent paresthesia is present about 15% of the patient. So these are the complications present to the patient depending upon the procedures, what procedure we are using, peripheral procedure or percutaneous procedure or central procedure. So depend upon the complication, we want to explain the patient, and depend upon the patient age and intensity of the trigeminal neuralgia attack pain things, we want to go for the select the correct surgical procedure. So this surgical procedure relieves the patient pain. Thank you for your watching.